Hello everyone. Um, for this session, I want to discuss with you prolactinoma's challenging encounters. I have 7 very difficult cases, and as I discuss, we will learn how to manage them and as we encounter difficult patients, and I hope you will enjoy these sessions. So let's get cracking. There is a common misconception, as Robert Knudsen says, that prolactinomas and pituitary tumors are rare, that they are benign, and they are easy to treat. If you actually listen to what I'm going to show you and tell you, you will realize that none of these are correct. Pituitary tumors are not uncommon. They can be benign but very difficult to treat. Some of them could be malignant, and they are not always easy to treat and requires a lot of clinical skill and remembering the basic concepts of management are always easy to not fall into pitfalls. So let's get moving. So our first case is this patient this young woman who presented with huge, what we call giant prolactinoma, because the size of the lesion was more than 4 centimeters with cavernous sinus invasion. As you can see here, the cavernous sinus on the right side is invaded. The optic chiasm is not seen, so as you can imagine, the visual fields will be very restricted, and with treatment there is almost complete shrinkage of the tumor. So this is an easy to treat patient, although the original presentation was horrible with cranial nerve palsies and with visual loss. You can see how you can expect a good result even in a difficult patient, and that makes people sit back and think that all prolactinomas are easy to treat. For the first time in the history of tumor management, we saw in the 1970s how using dopaminergic signals and restoring the inhibition to the prolactin producing tumors, we could shrink the tumors, and this was perhaps the first instance of a medically treatable tumor. Ever since bromocriptine, we have had various other agents, cabergoline, then there are varieties of them, quinagolide, we have somatostatin analogs, in particular pasireotide, which has come to the fore. So when you see a patient with probable prolactinoma, sometimes it could be so small that you may not visualize. Sometimes it's just a microadenoma, which is classified as a tumor less than 1 centimeter. It could be a macroadenoma. We also call very large, more than 4 centimeter tumors, giant prolactinomas. So that's a good lesson to keep in mind. When you are encountered with a patient with enlarged pituitary or high prolactin and menstrual and other gonadal effect, it could be due to hypothyroidism. Sometimes the pituitary could be hyperplastic and give you a tumor, so that's something important to remember. The commonest cause in medical practice of a high prolactin and menstrual disorders perhaps is medications, dopamine interfering medications like antipsychotics, the antiemetics, etc., which are given for gastroesophageal reflux disease, could all inhibit and elevate the prolactin production. You could have not just a prolactinoma but any other tumor that compresses the stalk and prevents the inhibition of the prolactin production, causing what is called the disinhibition hyperprolactinemia, where the stalk is compressed and as a result the prolactin is produced out of control. That could be one differential diagnosis that is difficult to distinguish, as I will show you. Then pituitary tumors itself could be tiny, they could be large, or huge and giant, and there could be no visible tumor in some patients. Just a few lessons to remember. Prolactin is easily measured but could easily be misconstrued as being pathological, whereas it could have been a physiological rise. So physiological rises could be just few things like the patient is stressed out, patient is after a disorder like seizure or any other serious illness. Venipuncture itself, some people who are needle phobic, just the needle puncture procedure could be a problem in such a patient. If you put an IV cannula, allow the patient to rest and then remeasure, that artifact could disappear. As I said, drug-induced antiemetics and antipsychotics are perhaps the commonest cause of hyperprolactin in medical practice. And then what is called the macroprolactin, immunologically active prolactin molecules that are hard to clear. They linger on in the blood without any other pathology. So you could have elevated prolactin in the presence of no other pituitary pathology. You could also have a large tumor like a macroprolactinoma, which gives rise to usually a large tumor in the pituitary. Should be large enough. If the larger it is, the larger the amount of prolactin we expect to see. So usually patients with macroprolactinomas, that is large tumors more than 1 centimeter, usually have a prolactin more than 3000. Stalk effect, the prolactin could be high but not as high as 3000. So some people take 2000 as a cutoff, some people will use 3000 as a cutoff. There perhaps 2000 to 4000 is a gray area. In the presence of a macroprolactin, in the presence of a macroadenoma, if you have a high prolactin, then you might have a huge tumor and the prolactin could either be normal or only marginally elevated, making you think of a stalk effect. Whereas if the prolactin levels are like in the hundreds of thousands, there is what is called an artifactual low value called a hook effect, which can be sorted out by 1:100 serial dilution and multiple levels being measured, which will easily show up. So in the presence of these difficulties, always do for macroprolactin we do PEG precipitation. For macroprolactinoma versus stalk effect, you need clinical skills as well as few other tips I'll show you. For hook effect, you need to look for a serial dilution measurement. If you are unlucky, you might encounter a poorly functioning pituitary neuroendocrine tumor, which is actually a prolactinoma, but because it's poorly functioning, the prolactin is not so high. It's lower than 2000, and you think it's a stalk effect rather than a prolactinoma. It is only diagnosed when you do surgery thinking of the stalk effect, and then you see, okay, that was a prolactinoma which was poorly functioning. So there are multiple possibilities of and where you can. So how do you actually work around this problem? What is the cutoff value that is reasonable to say, yeah, we are dealing with this problem and that problem? What is the effect of disinhibition, hyperprolactemia, in other words, stalk compression? Or what about macroprolactin in these people? So as a rule, if the tumor is small, less than 1 centimeter, prolactin is usually lower than 200 nanograms. Actually, in this patient, it was only 97. So you could have got away with the fact that this was you could have argued that this was a microprolactinoma, but it wasn't. It was actually invading laterally even at presentation. So this was a macroadenoma more than 1 centimeter. We expect prolactins to be 3000, some would say 4000 or 200 nanograms per ml. So if the prolactin originally wasn't so high, it was only marginally high, it responded quickly to treatment, then we are looking at trouble. If there is a macroadenoma, prolactin is not so high, the question is this a non-functioning pituitary adenoma? Is this just a stalk effect, or in other words, disinhibition, hyperprolactinemia is the question. we ask. So if you look at in vitro response of prolactin producing cells to the effect of dopamine or bromocriptine, you will see that there is within 4 hours the prolactin level starts to come down after treatment. So if you give dopamine, it goes up. You give again, it goes up. You give bromocriptine, it quickly comes down. You give the dopamine again, it goes up. So the bromocriptine response of normal pituitary cells is quite rapid, whereas tumor cells will respond more slowly, and that we use as a surrogate marker to differentiate between tumor and normal cells producing in the case of stalk inhibition. So this is that patient now with a large tumor, bitemporal hemianopia. Original prolactin was 97 nanograms, 3 times high, less than 200, which was the cutoff, and rapidly responded, which means it was disinhibition hyperprolactinemia. Because in prolactinoma, the prolactin comes down more gradually down as we treat them. So this patient at the beginning required surgery, which she received at the end of 3 years, but not medical therapy with cabergoline. We move on to case 3. This is a patient who presented with a giant prolactinoma with symptoms, headache, vomiting, visual impairment. She had galactorrhea, she had secondary amenorrhea. Prolactin was very high, it was sky high, 25 being the upper limit of normal. This patient had nearly 9,000. So what is the diagnosis? She was diagnosed to have prolactinoma. She was given cabergoline treatment. In 6 months, the prolactin came down to twice the upper limit of normal. Tumor shrank, and in 6 years, the treatment remained. She remained responsive to treatment. This patient has giant prolactinoma, as you can see. She had a tumor more than 4 centimeters. Prolactin is usually way high. If they don't have such a high prolactin, you can look for hook effect with dilution. This should read nanograms, I apologize. So what was unusual here is that this is a young woman who has a giant prolactinoma. Usually there is a cause behind that. So prolactinomas could present as part of a genetic syndrome. It can present with as part of an MEN1 syndrome. These are patients whom I will show in a while who had this problem, and this is second patient is the one I am showing now, discussing now. It could also be part of an MEN4 syndrome, which is also like MEN1 with multiple gland problems. They could present, and there have been some papers that have been presented. These patients will be negative for MEN1 genetic screen, but will turn out positive for MEN4 gene mutation. Then there could be patients who have a pituitary adenoma and paraganglionoma syndrome due to the SDH mutation, and that has to be remembered. We also, I work with a lot of people who study AIP mutations in patients like the one we've described. So this patient has to undergo genetic screening to look for multiple endocrine neoplasia, SDH mutation, or AIP mutation. So the clue here was that she subsequently had this pancreas, as you can see, and a large lesion here. She was negative for other things. Gastrin was normal. Usually in other developed societies and countries where all the tests are available, this kind of patient will undergo proper biochemistry and testing. We do biochemistry as and when required based on clinical features. So this patient tested for MEN1 syndrome, which can present with the 3Ps, parathyroid adenomas, pituitary adenomas, and pheochromocytomas, but they could have various other tumors. As you can see, they could have lipomas, angiofibromas, meningiomas, and so on. So when we did once we discovered she was MEN1 positive, we also described she was not just having prolactinoma but pancreatic neuroendocrine tumor and hyperparathyroidism. She underwent surgery for all of them, and we also discovered that her brother tested positive and had hyperparathyroidism, and the cause here is that her mother had hyperparathyroidism. And the rest of the family needs testing on the maternal side to look for not just these people, but if one of the siblings of the mother tests positive, then you can go down that family to offer. So this is like a detective work where you can offer genetic screening and test people before they manifest these manifestations. We move on to our next case, case 4, a 9-year-old boy who presented with huge tumor. This is actually one of the youngest patients ever reported in history, with a prolactin now nearly 10,000, which is 25 being the upper limit of normal, remember. So he underwent, he was given cabergoline therapy. Prolactin responded in 8 months, remained normal for up to 3 years, and then the prolactin started rising. The tumor came back. He had surgery, followed only with partial resection with radiotherapy. He also, as you can see, manifested multiple other problems. This is the recurrence of the tumor, original response, and then recurrence. He had hyperparathyroidism, he had neuroendocrine tumor in the pancreas with insulinoma, and when we tested him genetically, he had MEN1 syndrome with multiple endocrine neoplasias. His brother is positive, his father is positive, so father's side needs testing. Lots of them are diseased, but the rest of the family needs screening so that we can offer them counseling and treatment. Not my patient, but case 5 is a patient from a recent publication that has been shown, which was published last year. But I've seen many patients like this. So what's unusual here is that this is a 73-year-old, very unusual compared to other patients that we normally see. She had high prolactin. She also had been treated for hypertension. She had been amenorrheic from the age of 27. She had headache, diplopia, so she definitely required evaluation. Because of the hormonal features, she had prolactin that was tested, and that showed very high, and you can see there is a prolactinoma in her brain, but there is something unusual, and if you do angiogram, you find that she actually has an aneurysm coexisting with the prolactinoma in these patients. There are multiple reasons why patients with prolactinoma could have intracranial aneurysm. It could just be the tumor invading, it could be hemodynamic factors, it could be localized atherosclerosis, it could sometimes be the hormonal abnormalities giving rise to that. This patient also had hypertension, as you can remember, so that's one of the causes. So how do you treat these patients is a conundrum. The options are, there are 4. Treat the aneurysm first, because that's the one that's causing symptoms and signs here. So you can do an endovascular procedure and then settle it and then do transsphenoidal surgery. Some people would say let's do transsphenoidal first, but then it's a very high risk procedure because there is an aneurysm sitting next to the tumor, so it's high risk and endovascular treatment is done later. You can do combined surgery for both, but remember that endovascular surgery is the preliminary choice for and not invasive surgery for these patients. medical treatment of the tumor to shrink it, and then doing intra-aneurysmal clipping is another way to do that. Most people would do the first option, treat the IA first and then treat medically. In this patient, they saw that this tumor and the aneurysm were adherent together, so they were reluctant to give medical therapy until they to shrink the prolactinoma, I mean. So they wanted to first do endovascular coiling, shrink the aneurysm, and then treat the patient. Otherwise, they thought that the patient could develop ICH by this tumor shrinking, moving away from the aneurysm to which it was adherent, and it could give rise to problems, they thought. So they did this procedure. The aneurysm shrank. The other option is to put an FD device to shunt the vessels away and the blood flow away from the coil, which was required in this patient later because she subsequently developed recurrence of the aneurysm, at which point a coiling and an FD device were inserted. Prolactinoma was, of course, subsequently treated medically. So let's move on rapidly in the interest of time to prolactinoma in males. In males, it tends to be slightly different. As you would have seen, most of the patients are ladies. Men tend to have large tumors at presentation because small ones are usually asymptomatic, and women are more sensitive to high prolactin than men. So 13% of the tumors do not shrink and are resistant. Testosterone can be aromatized in males, so you can perhaps use aromatase inhibitors, which is coming up as a new therapy for men. Men also tend to develop more impulse control disorders. 25% of the men treated with therapy could develop impulse control disorders, so you need to watch out for this problem and assess their personality and psychiatric status before you start treatment in men. Just like anybody else, treatment options are multiple. You can do surgery, you can do medication. In difficult patients, it could be temozolomide and aromatase inhibitors. It can be treated with radiotherapy. This is a new study that shows that aromatase inhibitors can inhibit tumors and cause apoptosis. So my case 6 is a 19-year-old boy who had a giant prolactinoma, 6 centimeters, with a prolactin of 10,000. He had ACTH-TSH deficiency. He was given bromocriptine and then switched to quinogolide. This once again is from a publication. He developed depressed mood. He had gambling tendency. He started playing with gaming machines and online casinos. He gave up studies. He lost even 5,000 euros in one day, and to fund it, he used his father's credit cards. He would play. Even if he win, he would just keep playing on and on until all the money he won would be gone. So he had compulsive gambling. He had multiple he was involved in multiple schemes to fund his gambling habit and had a debt of about 200,000 euros. He was put in prison for this behavior. But if you look at patients like that, their striatal area lights up because of the increasing dopamine in those areas, and that can be tested with functional MRI. So if you look at patients like this, also patients who sometimes develop psychosis as a result of cabergoline therapy because of the various neuro changes that occur in the dopamine levels within the brain and in the striatal tract, etc. Also patients who are sometimes psychotic and have tumor, we have this conundrum of how to treat them. These are the 4 options: switching to prolactin sparing antipsychotics, adding aripiprazole, which is coming up as the number 1 choice. Actually, I have some patients with psychosis developing after cabergoline, in whom we use aripiprazole. One of my patients has now recently required more than aripiprazole, so we, along with psychiatrist, I use prolactin sparing antipsychotics. Aripiprazole alone can shrink tumors, prolactinomas, because it's partially effective, partial agonist and partial antagonist, so it can be used. Aripiprazole plus cabergoline can also be used. Some people have tried metformin with varying results. We have tried in a few patients with not much positivity. So you have two options: either switch to aripiprazole or give aripiprazole and add cabergoline in the end. So, ladies and gentlemen, as we've seen, dopamine agonists are the key treatment in prolactinomas, but they must be used wisely because they can give rise to adverse effects, and therefore used wisely. So my last 7th case is not, although we say lucky 7, this patient is not such a lucky patient. She presented with third cranial nerve palsy on the left side, as you can see, because she had a tumor not shown in here, but in the other sections, cuts, you could have appreciated that she had a tumor, a giant one, invading her cavernous sinus. She had a prolactin very high. She was hypopituitary with a low T4 and a low cortisol. Although the TSH is normal, you can appreciate secondary hypothyroidism here. Patients who present with cranial nerve palsies may require surgery, not to use cabergoline as the first line agent. Some of the indications now include macroadenoma with compression, which is not responding to treatment, but some patients might choose to go for surgery as the first line agent. Apoplexy requires decompression surgery. Resistance to treatment or recurrence, as you've seen in some of our MEMIAN patients, is an indication for surgery. If there is a cystic lesion, it is thought to respond poorly to medical management, but even they could shrink. So if they don't shrink adequately in 3 months, then you can offer them surgery. Some of the tumors, as they shrink, they lift away from the cribriform plate which sits under the pituitary, and as a result of the tumor shrinking, the previous erosion now is revealed, and CSF leak could occur from there. So these patients require sealing of the CSF leak because the floor of the pituitary sella is now eroded. So as you patch it, you might want to also remove the tumor, which is what most neurosurgeons do. There could be a few medical reasons why you offer surgery to patients, like woman who wants to conceive, a patient who is refractory to treatment but who can't wait because she needs to conceive. Psychiatry patients who have complex medical management to be done might have to undergo surgery if they want to, and so on. So this patient who presented with high prolactin, very high, as you can see, nanograms per ml, 4000 was the original prolactin. She responded partially to 3725 being the normal, and then the prolactin started rising. Then she underwent further therapies. As it rises, you can see surgery and radiotherapy are options at this moment. So it all depends on the age of the patient, what does she want, etc. She responded, she didn't want surgery, so she underwent radiotherapy, went down, and then it started rising and did not get control. So at this moment, I will take you through what's happening. So she's having a tumor which responds, but then the prolactin is rising, as you can see in the graph. Do we do surgery? This patient doesn't want surgery at this moment as the tumor comes back. So she gets radiotherapy. Next year, she comes back. Tumor is somewhat under control, but the prolactin is not fully. But we see a scalp nodule, which the patient can feel. A few months later, she has lesions in her humerus, and shoulder pain. X-ray shows this lesion. As you can imagine, the scalp lesion was positive for prolactin and Ki67, and this is the bone uptake scan, which shows multiple bone mets, and here there is one. So this is carcinoma of the pancreas, actually malignancy with secondaries all over. So at this stage, she had LINAC radiotherapy to the shoulder and scalp and offered temozolomide. Temozolomide, if they are MGMT positive, they respond well, as you can see from studies. And this patient underwent that. So ladies and gentlemen, as you can see, size alone does not determine how patients respond. We saw 7 cases. Some of them with smallest tumors were the most difficult to treat. Sometimes giant prolactinomas shrink originally, but then later recur because these patients have various other problems, either malignancy or they have multiple endocrine neoplasia syndrome, etc. And so with that, I'll conclude. I hope you learned the lessons from this presentation, and I thank you for listening.